Hello and welcome to our orientation seminar for weight loss surgery. I'm Brian Gluck, bariatric surgeon and director of bariatric surgery at Trinity Health, Muskegon. During the course of this seminar, I'm going to tell you about our program. You're going to meet several team members, and we're going to explain to you why bariatric surgery is the most effective long-term treatment for obesity. We started our program 20 years ago. I have performed over 7,000 bariatric surgeries, but more importantly, we have an advanced before and after program that equips patients for long-term success with their bariatric tools. We are nationally accredited by the American College of Surgeons. The American Society for Metabolic and Bariatric Surgery defines obesity as a disease in which fat has accumulated to the extent that health is impaired. We measured by body mass index, which is a measure of height versus weight. We operate on patients with class 2 and class 3 obesity. So many people think that obesity is due to an imbalance in calories in and calories out. Well, that is only a very, very small part of it. There's environmental factors, genetic factors, certain diseases, medications, hormonal triggers, and even altered gut microbes that can cause it. Obesity has become a national disease epidemic. Almost 42% of U.S. adults are obese. It contributes to a decreased quality of life. Obesity can affect every major organ system in the body, such as diabetes, high blood pressure, coronary artery disease, sleep apnea, to name a few. Also, obesity is a cause of many cancers: breast cancer, uterine cancer, cervical cancer, colon cancer, esophageal cancer, pancreatic cancer, and kidney cancer. As you become more obese, your risk of getting these comorbid conditions increases, such as diabetes, hypertension, and arthritis. Even your years loss of life increases. With patients who are 100 pounds overweight, they will die 13 years earlier than someone of normal weight at the same age. So yes, diet and exercise are important, and even 5 to 10% of weight loss can improve cardiovascular risks. But diet and exercise alone don't really get it. There's a 95% failure rate for long-term success. So a 200-pound patient fighting obesity with diet and exercise alone would only be able to achieve sustained weight loss of 4 pounds over 20 years. There are several newer obesity medicines out that are promising, but they're still not there yet. There's many side effects, medication interactions, and contraindications to their use. Insurance companies only cover a select few of these, and some of these are quite expensive, costing $1,600 a month to $20,000 a year. Probably the best one out there so far is Wegovy, an injectable once-a-week medicine. This is an advertisement from them, and they advertise that adults lost on average 35 pounds. So that patient who was 232 pounds in their study lost on average 35 pounds. Well, so now you're 197 pounds. That's still not really where you want to be, and with bariatric surgery, we could probably get you down at least twice that much in weight or even more. Why can't a person lose weight? Some of this has to do with the metabolic set point. Your body wants to keep you at the weight you are. As an adult, the set point is set. So when you go on this reduced calorie diet, physiology reacts and causes these hormones to try and keep your body from losing weight. So your appetite increases, your digestion increases, your energy balance decreases, and your metabolism decreases. So in essence, the weight is regained. One of these hormones is ghrelin. Ghrelin is an appetite-stimulating hormone. When you diet, ghrelin levels increase. As you're dieting, ghrelin levels go up, and finally you say, forget this diet, I'm going to eat. Well, problem is, ghrelin levels don't come back down to normal until you've gained more weight than you've lost. Bariatric surgery can change this. Here's another way of understanding it. I want you to meet Amanda.
Let me introduce you to Amanda. You're just meeting her for the first time, but chances are you're already making assumptions about how much she eats and how little she exercises because she's obese. But I'm about to show you that there's much more than meets the eye when it comes to obesity, There are lots of Amandas out there, and they need treatment. Maybe you're one of them, or maybe you know an Amanda. It's time to act on obesity. But in order to do so effectively, we need to understand obesity. It's generally accepted that body weight is determined by a pretty simple formula. We call it the energy balance equation, and it works like this. If the number of calories that you consume equals the number of calories that you burn, your weight remains the same. If you consume more than you burn, you gain weight. And if you burn more than you consume, you lose weight. Most people think that those of us who properly manage our energy balance remain lean, whereas those of us, like Amanda, who eat too much and exercise too little, become obese. We view obesity as a lifestyle choice, and the cure for it is simple: eat less and exercise more. This may sound logical, but it's wrong. Let me explain. First, let's talk about set point. No, I'm not talking about the point in a tennis match when one player is about to beat the other. I'm talking about a theory that says that no matter what you consciously want your weight to be, your brain has its own sense of how much body fat it should have on board, and it has a complex system in place that very precisely regulates your energy intake and expenditure to keep you within a so-called set point range for body fat. So that whole energy balance equation, it's not something that you control voluntarily. Your brain regulates your calories in to your calories out for you. For your brain to do this, it needs to know how much energy you have on board at all times. And it knows this by listening to hormones like leptin, which is made in your body fat. You can think of it like a car. Leptin is the gas gauge that tells your brain how much gas is in your tank. But leptin is just one piece of the puzzle. You've got a whole bunch of other hormonal signals and sensors that are involved too. Your bones, muscles, pancreas, liver, GI tract and sensory organs, they all play a role, communicating with your brain to give it the information it needs to do its job. But that's more detail than we need for this conversation. The point is that you have a complex system in place that regulates you to within a set point range for body fat. So what happens if Amanda decides to lose weight by going on a diet? After all, people with obesity should eat less, right? Here's what happens. She loses weight, but her hormone levels change. Her brain hears this, and it starts acting to restore whatever body fat she's lost. She feels hungrier, and although she doesn't know it, she's also burning fewer calories than before. You see, set point is usually a one-way street. Once it's been elevated, the brain works to defend it just as vigorously as it would a lower set point. Amanda's brain doesn't know that she needs to lose weight. It only knows to defend her current set point. Back to our car analogy. Amanda can't help but look for a gas station to refuel when she sees that her gas gauge is low. At the same time, she becomes more fuel efficient, burning less energy than before. This might explain why treating obesity with diet and exercise so often fails to produce the desired results. It's sort of like telling Amanda that she needs to be a more careful driver, when the real problem is that she needs a mechanic to fix her car. Okay, so if we've all got this complicated system in place that prevents us from losing weight, why doesn't it also protect us from gaining weight and developing obesity in the first place? How can we explain the obesity epidemic? Getting back to Amanda, why did she develop obesity? The answer is that it takes a perfect storm to cause an obesity epidemic like the one we're seeing now, and it's our modern environment that places us, and Amanda, directly in the path of that storm. While there's no single cause for the rising rate of obesity, changes to the chemical and nutrient content of our food, the so-called Western diet, a decrease in physical activity, increased levels of stress, inadequate and disrupted sleep, and more widespread use of medications that promote weight gain all play a role. Our unique genetics and developmental histories cause each of us to respond differently to these elements of the modern environment, and some of us, like Amanda, respond by sending hormonal signals that elevate our set point for body fat. It's not that Amanda's system has stopped working, it's just that it's working to regulate her to a set point that's too high. So you can think of obesity as a biological response to the modern environment, a disease where the body dysregulates to a body fat set point that is too high. Back to our car analogy. The size of Amanda's gas tank has expanded, so she carries around too much fuel. So now that we've looked at one of the theories behind why obesity occurs, Let's look at theories of how it occurs. It's often assumed that obesity in people like Amanda is a result of a massive imbalance to their energy balance equation, that their intake vastly exceeds their expenditure. But is this always the case? Consider this. If you're an average person, you consume about 900,000 calories per year. And it's true that you need to burn 900,000 calories to avoid gaining weight. If your energy balance were to be off by only 4,000 calories, an error term of less than 0.5%, you'd gain a pound every year. If you break that down, we're talking about a mismatch of 11 calories per day, the equivalent of approximately 2 potato chips. If your intake were to exceed your expenditure by just 40 calories per day, the equivalent of 1 pretzel rod, you'd gain about 150 pounds between age 25 and 65. So there are 2 points here. 1. If you're maintaining your weight, you're doing so because your body is matching your energy intake to your energy expenditure more precisely than you could ever do consciously. So it stands to reason that your system plays a role in doing it for you. And 2, people may gain weight not because their energy intake wildly exceeds their energy expenditure, but because of a very slight mismatch between the two. For Amanda to lose weight and keep it off, she needs to find a way to lower her set point. That is, rather than declaring war on her own biology, she needs to find a way to make her body regulate itself to a new, lower weight. One option for Amanda to consider is bariatric surgery. In study after study, it's been shown to be the most effective long-term treatment of obesity. But how bariatric surgery works is often misunderstood. Most people, even many doctors, think of bariatric surgery in terms of restriction or malabsorption. It's a reasonable assumption that surgery would work in these ways. After all, the procedures usually consist of some combination of altering stomach anatomy to be smaller, which you'd think would restrict the amount of food that you'd be able to eat, and rerouting the GI tract in a way that you'd think would make you fail to absorb the calories that you do eat. But new research suggests that certain types of bariatric surgery, for example, gastric bypass, sleeve gastrectomy, and duodenal switch, affect the signals between the brain and the body to decrease appetite, increase feelings of fullness, increase metabolism, and even encourage preferences for healthier food. Surgery may change the set point for body fat. It's like the anti-diet. Instead of fighting the set point like a diet does, surgery may recalibrate it, and the hormones that stimulate weight gain when a person diets do the exact opposite after surgery as the body regulates itself to the new lower set point. So here are 3 things you can take away from all of this. 1. Energy balance is complex and highly regulated. 2. Obesity is a disease where the complex system that regulates body fat may dysregulate to a set point that is too high. 3. Bariatric surgery may work by changing the signals that regulate body fat set point, enabling patients to successfully lose weight and keep it off. It's time to reshape the conversation about obesity. It's time to look past diet and exercise as the only treatment solutions. It's time to act on obesity. And now that you've been educated, here's a simple way for you to act. Share this video.
So bariatric surgery has a unique mode of action that allows for metabolic change versus caloric restrictions, as with dieting. It has the greatest weight loss results of any treatment option. It has the longest weight loss duration and has the ability to reduce or resolve comorbidities. It has been shown to significantly improve quality of life and even helps reduce mortality. Surgery is like the undiet, whereas a medical diet will increase your appetite, surgery decreases it. Medical weight diet increases hunger, surgery decreases it. Medical weight diet decreases fullness, surgery increases it. The reward-based eating, that want for the sweets or the cakes or the candies, the reward-based eating in diets get increased. You want that sugar, you want those carbohydrates. Surgery decreases it. Even your energy expenditure in surgery is increased, causing you to lose more weight, and your stress response is decreased. The most common bariatric surgeries today are the Roux-en-Y gastric bypass, which creates a small pouch in the stomach and reroutes the intestine. There's also the vertical sleeve gastrectomy, which creates a sleeve of stomach, almost like a banana, and removes about 80% of the stomach. The adjustable gastric banding was a band that went around the top of the stomach. You inflated it so it almost was like a noose around the top of the stomach. It does not have any hormonal effects, so people can't eat and they're hungry, and it didn't work in the end. And I think it didn't work because of the hormonal effects. Well, I'm glad to say I never put in any. I certainly take out a lot and convert the band to gastric bypass or to sleeves. As a matter of fact, recently I took out a band and converted the patient to a sleeve. The patient had lost 20 pounds in 2 years with the band, and after 5 weeks with her sleeve, she was down 45 pounds. Again, the band doesn't work. No one should be doing these. So with gastric bypass, we create a small pouch, 15 to 30 cc's, and reroute the intestine. So it's basically a restrictive and malabsorptive procedure, but more importantly, it's a metabolic procedure. There's no implanted medical device needed. There's a low rate of complications, but again, it changes your hormonal signals.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgeon examines the abdominal cavity using a laparoscope or video camera. A small stomach pouch is created using a stapling device. This smaller stomach pouch restricts the amount of food that can be eaten before feeling full. The small intestine is separated into 2 sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. Bypassing a portion of the small intestine decreases the absorption of calories and nutrients. The upper portion of the small intestine is reconnected to the lower portion of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
Roux-en-Y gastric bypass considerations. Leaks can occur, disruption of the staple line. Nationally, leak rates are about 1%. For me, my leak rate is 0.1%. People with gastric bypass can get dumping syndrome, which means if you eat fatty foods high in carbohydrates, candy, cake, you get dumping where the body will react with crampy abdominal pain, diarrhea, nausea. You'll start sweating as well. Sometimes there's reactive hypoglycemia. Again, you eat something too high in carbohydrates, the body's blood sugar count will go up and then drop it rapidly. There's more vitamin and iron deficiencies with gastric bypass than with a sleeve gastrectomy. You could get strictures. Another issue with gastric bypasses can be marginal ulcers, an ulcer that forms between the pouch and the intestine. And for that reason, we don't want people with a gastric bypass to take any anti-inflammatory drugs like Motrin, Advil, ibuprofen. We don't want you smoking, and we don't want excess alcohol consumption. With gastric bypass, there's certainly risk of bowel obstructions or internal hernias, and with any bariatric procedure, weight regain can always be an issue. Vertical sleeve gastrectomy. This has become the #1 procedure in the world today. The gastric sleeve is probably my favorite procedure. There is, again, no implanted medical devices. It's a metabolic procedure where hormones change. And it's got low risk, and it looks like this.
The sleeve gastrectomy is a restrictive procedure, which limits the amount of food you can eat by reducing the size of your stomach. To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. Surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdomen using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes to help break down the food into a more simple form so that it can be more easily digested and absorbed once in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 to 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. The newly created gastric sleeve is able to hold approximately 1/10 of what the stomach was able to hold before. This smaller stomach sleeve restricts the amount of food you can eat before feeling full. The bile and pancreatic fluids from the liver and pancreas mix with the food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments necessary for the sleeve gastrectomy. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
Anytime we do a sleeve, again, leaks can occur nationally. Leak rates are up to 2%. For me, my leak rate is 0.2%. You could have food intolerances. There can be narrowing where the angle of the stomach occurs. Probably one of the biggest issues after a sleeve for some folks are reflux. And I don't think it's reflux really caused by the sleeve, but it's reflux after 4 years, 6 years, 8 years out. People start eating more, they put more into their sleeve, too much into their sleeve. That causes reflux. Because of that, they gain weight, and that causes reflux. So it's very important to stick to your diet protocol. The sleeve has less nutritional and vitamin deficiencies compared to the gastric bypass, but you still have to take vitamins. And with any bariatric procedure, there's always a chance of weight regain if you don't do what you need to do. When the sleeve first came out, it came out as a staged procedure. People thought that, well, okay, if you can't do a gastric bypass, do a sleeve, get the person down in weight, and then because the gastric bypass may have been technically too difficult because of the patient's size, they lose some weight, you bring them back for the gastric bypass. What we thought when we started doing sleeves is, sleeve is a great primary procedure, especially for patients with lower BMI. And we did a study that was published and showed that the sleeve gastrectomy is a safe and effective procedure for those patients with BMIs of 35 to 43. So again, risk of bariatric surgery, anytime we do surgery, you could have bleeding, infection, anesthetic problems. Big thing with any obese patient having surgery is blood clots. You have to get up and move. We really enforce that. We want patients to move several times after surgery and in their post-operative course. There can be staple line leak, as we mentioned, wound infections, gastroduodenal strictures, nausea, vomiting, reflux, bowel obstructions, to name a few, and we'll go over these in more detail in the office. While the list of potential complications may be concerning, the risk of long-term obesity can be much greater. We are proud of our long-term commitment to safety, which has resulted in low complication rates for our program. Our overall percent excess weight loss for gastric bypass at 1 year, 72%, which means that if you're 100 pounds overweight, our average patient at 1 year lost 72 pounds, versus a sleeve, if you're 100 pounds overweight, our average patient lost 66 pounds. So not much difference in the two, both great procedures, and we could certainly talk about which procedure is right for you. A little bit about comorbid resolution. Hypertension, we see over 90% improved or resolved. Diabetes, over 90% improved or resolved. High cholesterol, over 90% improved or resolved. And even sleep apnea, over 90% improved or resolved. By 6 months, most of my patients don't even use their CPAPs anymore. They don't need them. We are a American College of Surgeons accredited center. I actually am one of the reviewers for the MBSA QUIP. I was the first osteopathic surgeon to get that honor to review other hospitals. Now I probably review 6 to 8 hospitals a year and make sure that they are doing what they need to do to be a accredited center. We are also a Blue Distinction Center for bariatric surgery, one of the few in Michigan. A little bit about my personal life. For me, bariatric surgery is more than just doing surgery. That picture of the overweight kid here is me when I was 10 years old, approaching 200 pounds, in a time when childhood obesity wasn't prevalent. I had a sister who was also overweight, and she was going to high school, and she found a camp in New York for overweight kids to help them lose weight. We were fortunate enough that my parents sent us there, and we were able to lose some weight at the camp, and then we came home, and I lost probably close to 100 pounds that year. And to this day, I've kept it off with diet and exercise and just living a healthy lifestyle. I could do that because my set point wasn't set yet as a child. As an adult, it's nearly impossible. I've lived in West Michigan for 26 years. This is my family, my 2 sons and my wife Jennifer, who you'll meet shortly. And then that's my 2 dogs. We had 2 boys. My wife really wanted a girl, so I did the best I could do and got her a couple girl dogs.
Hi, I'm Jennifer Gluck, Bariatric Surgery Coordinator in Muskegon. Thank you very much for your interest in our program and spending your own personal time to watch this virtual seminar. As a coordinator, I serve as a link between the administrative and clinical bariatric team members from the hospital and the office setting. I'm going to give you a brief overview today of things you can expect should you choose to proceed, and also talk a little bit about our team. This diagram depicts a bird's eye view of the pathway to bariatric surgery. It's kind of a complicated pathway, and we're not going to talk about every aspect, but take note that the first bubble reflects the first step as being the bariatric surgery seminar. So congratulations on completing the first step. Some things from that diagram that you can almost always expect is medical testing, nutrition education, behavioral health evaluation, behavioral health support in the form of support groups and events are encouraged both before and after surgery, and then pre-surgery weight management visits are sometimes required, but not for all patients. This may sound like a lot, and that diagram may look a little bit overwhelming, but it has purpose, and each step is essential for a safe and effective outcome. Our intent is certainly not to deny or delay anyone's surgery, but to get you ready for success physically, mentally, and emotionally. How do we do all of that? Through our multidisciplinary team. Our team consists of a well-trained surgeon, physician assistants, registered dietitian, behavioral health professionals, bariatric surgery coordinator, bariatric case manager, exercise specialists, registered nurses trained to take care of the bariatric surgery patient, and a compassionate clinical and administrative staff. Our team works hard to lead patients toward long-term weight loss success by providing education, support, and guidance both before and after surgery. We do this because our patients deserve the best possible chance for success. I hope you enjoy learning more about our program today and hearing more from other team members in this virtual seminar.
Hi, I'm Sue. I'm case manager for bariatrics here at Trinity Health, and today I'm going to talk very briefly about what my role is as part of the team here, and then also about what you can expect the day you come in for surgery. So what do I do? As a case manager, I work alongside your bedside nurse to help coordinate your care. I will be the one reviewing your discharge instructions when you leave. I am also the resource person for the staff and the nurse educators to keep everybody up to date on what's going on with the bariatric patients and keep everyone current. The day of surgery, you come in, they'll get you ready in the pre-op area, you'll have your surgery, you'll go to recovery, and then you'll be there for an hour or so, and after that you will go to your room. When you start to wake up, you'll notice that you have anywhere from 5 to 7 little incisions, and you'll have a little Velcro wrap around your abdomen that helps just support those incisions. You'll have a little oxygen on when you first wake up. You'll be able to have a little bit of ice to wet your mouth. Within a couple of hours, we're actually going to have you up moving and walking, and if you have pain or nausea, we're going to take care of those things for you, and we will continue that process throughout your stay. When you do go home, and some people do go home the same day, some people stay, but whenever you do go home, it'll be my job to come in and sit down with you, and my pleasure also, to sit down with you and go over your instructions. And I will do that, and we will go over them line by line, clarifying things, answering questions, making sure you're very clear on what's expected when you go home. I also like to let people know that I'm also a patient. I had surgery in 2003, so I get where you're at. It'll be my pleasure to sit down and discuss things with you, and I look forward to seeing you at the hospital.
Hi, I'm Tricia Anderson. I'm a physician assistant. I've worked with Dr. Gluck in his program for the last 10 plus years. I work alongside Kelly Laskowski and Riley Butler, who are also physician assistants with our office. Together we have more than 45 years experience, and in the office 25 years experience. Kelly's been with the team since 2007. I joined in 2012, and Riley's our newest member. Some roles of the physician assistants in the office: we do your preoperative weight management visits. We also assist in surgery. We do hospital rounds. We'll see you following your surgery to help you to get to your goals and to manage your care after surgery. We do triage throughout the day. We see you for back on track visits if you've experienced some weight gain. And we're responsible for a lot of the program management and development, as well as leading support groups and various events that the office has. We also run the non-surgical weight management program in the office. So our preoperative weight management visits might be required by your insurance company. Sometimes they're a recommendation by Dr. Gluck or the psychologist that you meet with. These shouldn't be viewed as punitive. Nobody wants to stop you from having surgery, but we do want you to be ready for surgery. This can be an excellent time to educate yourself on the surgery itself and the strategies that you're going to have to adopt for success. It's our recommendation at these visits that you're starting to make those lifestyle changes. One thing that I find helpful during these visits, if you're discovering the problem areas, things that might stand in your way of getting to your weight loss goals or possibly regaining weight down the road. Problems such as grazing on foods throughout the day, or eating when you're bored or when you're stressed or when you're emotional. Sometimes it's the opposite problem in that people aren't putting enough nutrition in throughout the day. But we can help you with those problem areas and give you recommendations and help you to get closer to where you should be even before having surgery. Exercise is something that we really encourage during these preoperative visits. We encourage you to set achievable goals, prioritize exercise in your schedule, and don't get hung up on the things that you can't do, but rather focus on the things that you can do. Building supportive relationships and environments that you are in throughout the day can be a really helpful thing to do before surgery. If you know anybody who's had bariatric surgery, they might be good phone calls to make just to get inside their head to see how they've done and what recommendations they would give to you. Certainly you can invite family and friends. The environment piece, I would recommend that if you're having a lot of junk foods in the house, maybe you start to look at how that could be different so that you aren't surrounded by those easy bad food choices. The biggest thing I say to patients throughout these visits is practice being a bariatric patient. As if you already had surgery, how would today look different than it would otherwise? The work that you put in before surgery is going to pay off, so just keep that in mind if this is a requirement for you. A couple considerations before surgery. If you're a smoker, you're going to have to be nicotine-free for at least 2 months before we do surgery. This includes cigarettes, nicotine patches, nicotine gum, vaporizers that have nicotine in it. The reason being is nicotine can be a big source of gastric leaks after you have surgery, and that would be very dangerous. Another consideration is the exercise piece that I talked about. We have studies that show that patients who exercise regularly up until an elective surgery have less complications from the surgery itself. So that's something to really consider and to implement in your lifestyle. For female patients getting ready to have surgery, if you're considering family planning, we recommend that you go 12 to 18 months after surgery before you conceive a child. And that's just because we want you to meet your weight loss goals, but also be nutritionally healthy to support and carry a baby. The following slide looks a little messy, lots of boxes there, but this is our post-op plan after your surgery. The first year can be quite intense. We see you a lot that year. Within the first 6 weeks, Dr. Gluck's going to see you twice just to make sure that you're healing well from the surgery. He wants to make sure that if you're experiencing any complications that we catch that early. There's a lot of education to be given that first year and a lot of monitoring. As you're losing weight rapidly, we're going to want to make sure that we're checking with you to see that your blood counts and that your kidney and liver function and your vitamin and mineral levels are staying healthy. Maybe you're experiencing some symptoms from the surgery or from the weight loss. Those could be physical symptoms or emotional symptoms, and if we're seeing you frequently, we can talk to you about those and problem solve. Another factor, of course, is to make sure that you're complying with the dietary recommendations and the exercise recommendations that we give you. Adopting this new lifestyle can be difficult, and we want to make sure that you're progressing with that and getting to where you want to be with your weight loss. One of the best things about the first year after surgery is managing and monitoring those comorbidities that Dr. Gluck talked about. It's frequent that we get to take away blood pressure medications or reduce doses of diabetes medications or take away cholesterol medicines. So we hope that that's an experience that we get to do during these visits. Accountability is a big factor after bariatric surgery. And in this first year, it's really important that you're honest at these visits, that you discuss your habits with openness and your choices with openness. Don't be afraid that we're going to get after you. We're here to help you and support you. Trust Dr. Gluck and his team. We've been doing this for 20 years and we've had 7,000 patients come through the door to have bariatric surgery. And we know that this is a struggle to adopt new lifestyle choices and changes. So we can help you if we know that you're struggling. Long term, I say frequently, obesity is a chronic disease, and it's going to require that you manage it forever after you have surgery. The surgery itself is a tool. This is a word that we use frequently, but you must use that tool diligently and make these modifications lifelong. Follow the guidelines, stay connected. We recommend that you keep an annual office visit, if not more. If you tend to struggle or get off track, we'd want to see you more often. In addition to office visits, we also have a very active Facebook page and support groups and exercise events that are meeting regularly throughout the month. As I mentioned before, accountability is really important to implement in your life to make sure that you don't lose sight of all the hard work that you've put into this journey. Frequently, I have to talk to patients about making their health a priority, and sometimes the best way to do that is to remember where you started. Thinking right now as you're viewing this video, how many difficulties you have because of your weight. Don't let those factors get out of your sight, because if you don't stay on task, it's easy to return back. One last piece is to make sure that you're frequently coming back into the office, or at least annually coming back into the office, because recommendations can change, and we want to keep you posted on that. And your body changes. It's important that we monitor your nutritional levels at least every year if you've had bariatric surgery, even if they've been okay for years prior. You are our patient for life when you choose to have surgery with us. Is weight regain possible? I kind of touched on it in the last slide. It absolutely is possible. The truth is that the surgery itself has a low risk of failure, but there's a lot of behaviors that have to be changed in order to maintain your weight loss. A thing that I say frequently to patients is out of sight, out of mind, and that's not helpful for weight loss maintenance. Sometimes you have to be intentional at participating in support groups or coming into the office just so that you can keep this in sight and keep focus on this piece of life and keep this disease at bay. If you're struggling with weight gain, the best thing that you can do is pick up the phone and call us and get in for an office visit. There's no shame in regaining your weight, but it's an awful shame when people don't come back to get support and help with it. I've mentioned multiple times that there's support groups, classes, events. Also investing in counseling might be a helpful strategy, but long-term success is possible. Lastly, I'd like to conclude with just discussing some barriers that I hear people say as far as going forward with surgery. I think a lot of patients who've struggled with obesity have had negative experiences in the medical care system. And I want to assure you that when you walk into Life Without Limits, you're going to experience staff that's compassionate and passionate about helping you to reach your weight loss goals. Sometimes there's a fear of surgical complications, and that's legitimate, but there should also be a fear of carrying extra weight and the damage that that's doing to your body right now. Sometimes there's a fear that patients aren't going to be able to follow the guidelines. That too, it's a difficulty, but if you prioritize this and you use the support, most patients are very successful. Another fear that patients sometimes have is how their body will look after surgery, after losing a lot of weight, excess skin or wrinkles. And yeah, that can happen. But I think it's a small price to pay when you look at the cost of obesity to living a long, healthy life. Fear of failure. I think most patients who come to us are professional dieters. They've probably tried hundreds of diets before they've even considered having bariatric surgery. But if you use the tool and you use the support, your chances of success are much higher with bariatric surgery than other diets and exercise. Sadly, I hear a fear of feeling judged by family or friends or coworkers. The common thing is, so-and-so told me it was the easy way out. I think that's a really ignorant statement that people make, because failing to take action on a disease is going to lead to a lot of problems for you down the road. And it's not an easy way out. You're going to have to do a lot of work in order for the surgery to help you with this disease. Lack of support, I hope that you see throughout our seminar here that there's an immense support group here just within our office, and we would love to help you if this is something you're interested in. I would end with just expressing one of the biggest things that I hear patients say to us over the years is their biggest regret is that they didn't do bariatric surgery. So I hope to meet you down the road, and good luck with your journey.
Hi, I'm Rebecca Slick, and I'm a registered dietitian. Part of my role as a bariatric dietitian is to educate and guide patients through essential dietary and exercise changes before and after their surgery. This will help to ensure their safety, promote a healthy weight loss, and support them in their long-term success. Some of my roles as a dietitian are to provide group nutrition classes, one-on-one nutrition counseling, lead support groups, provide bariatric program management and development, and engage in community outreach. What your nutrition support looks like. You'll attend a pre-op nutrition class to learn the basics about nutrition, diet, and exercise. Post-op nutrition classes to introduce you to each new diet phase. One-on-one counseling with a bariatric dietitian. Online resources include bariatric recipes, food journals, and exercise tips will all be resources available to you. And there will be monthly support groups to provide patients extra support throughout their journey. Your bariatric lifestyle in a nutshell. Incorporating a variety of lean proteins, veggies, fruits, and complex carbs. Drinking at least 64 ounces of hydrating fluids daily. Avoiding sugary beverages while limiting alcohol and excessive caffeine. Eating routinely and not skipping meals or grazing. Planning ahead for meals and snacks. Eating slowly, chewing thoroughly, and choosing appropriate portion sizes. Exercising above and beyond daily activities 4 more days a week. Taking a daily multivitamin and additional supplements, and creating positive and supportive relationships and environments. Benefits of exercise after surgery: improving and expediting weight loss, maintenance of muscle mass while promoting a healthy weight loss, ability to strengthen and build muscles, improved joint stiffness, improved satisfaction with weight loss results, less likely to regain weight, and improving energy, mood, and confidence. We want patients to focus on what they can do, not what they cannot do. You will have to participate in a pre-op liquid diet, which will start 2 weeks prior to your surgery date. The purpose of the pre-op liquid diet is to shrink your liver size, improving surgical safety and success, help to detoxify your body, and prepare you mentally for the weeks to come. The pre-op liquid diet includes protein shakes, protein powders and drinks, cream soups, high-protein soups, yogurts, pudding, milk and milk alternatives, and a variety of low-calorie beverages. We have 4 phases in our post-op diet. Phase 1, patients are on clear liquids for just 3 days surrounding surgery. Phase 2 will be that full liquids, which will continue for 3 weeks after surgery. Phase 3 will begin 3 weeks after surgery and continue until 8 weeks post-op. And phase 4 will start at 8 weeks post-op and continue till 6 months after surgery. Once patients get to 6 months after surgery, we teach them about a bariatric lifestyle diet. Some special dietary considerations that we can help with: patients who are vegetarian or vegan, who have lactose intolerance, gluten intolerance, intolerant to artificial sweeteners, patients who are following a renal diet, or diabetics. After surgery, the ability of your body to maintain certain levels of vitamins and minerals can be affected. Nutritional deficiencies can occur due to malabsorption, reduced absorption, caloric restriction, or other reasons. Some side effects that can be associated with these nutritional deficiencies could include anemia, hair loss, weakness, fatigue, dizziness, depression, blurred vision, and more. It is necessary for patients to take a multivitamin lifelong after surgery to help prevent these deficiencies, and in addition to help improve energy, immunity, and healing. Following the bariatric diet and maintaining regular office visits are also key components for avoiding deficiencies. We will monitor your labs routinely for the first year and then annually to watch for deficiencies. So success depends on you. Your success depends on how well you prepare and prioritize your health, commit to the program, set goals and utilize your support, adhere and comply to your new bariatric lifestyle.
Hi, I'm Dr. Mary Lukes. I am a psychologist and a board-certified behavior analyst. And I'm here to talk with you about mental health and obesity and why these two are partnered together. We look at our relationship with food, we look at work-life balance, stress, anxiety, and depression, trauma that could possibly lead to unhealthy eating relationships, eating disorders, unsupportive relationships. All these things can have an important impact on how we begin our journey, and we want to make sure that we're looking at everything very carefully. So the role of our behavioral health professionals, like myself, are to provide the pre-surgery behavioral health evaluation, pre-surgery support and education, post-surgery support and education, and then groups and individual counseling. So in the behavioral health evaluation, things that you should know, this is required to make sure that you're in the right place to be able to start this journey. And it doesn't mean that it has to end there. If you're not necessarily in the right place now, then we want to be able to help you get to that right place. So the purpose of the evaluation is for safety, readiness, and most importantly, success. So we hope that you will be thoughtful about giving a detailed history. It's not the intention to deny surgery, it's quite the opposite. It's to be able to identify any areas that maybe have an impact on your success, because that's what we all want. So we look at things like depression, anxiety, trauma, self-sabotage. That's something we often do to ourselves without even realizing it. Suicidality, eating disorders, addiction histories. These are all treatable. And so it's important to identify factors that could be contributing to some of those, or some that may be in your history, so that we can identify together with you how we can progress to get you where you want to be. You can expect in the evaluation to complete an online tool or a written tool. Again, none of these are designed to be tricky or to try to elicit things that are negative against you, but to support you. And sometimes we don't even realize some of the things that are kind of affecting us in the background, and this helps us strengthen and set up those goals so that we can support you for the best success. So we want to ensure success in your journey. And again, this is your journey. It's important to be introspective and reflective. So this means thinking about, why are we feeling the way we're feeling? Why are we, processing things in certain ways? Recognize and address your personal areas of concern, not what other people have told you or what other people might tell you are your concern areas, but your own feelings. Many people find journaling helpful to be able to write down. An example would be somebody makes a comment to you and you have a very strong, intense emotional reaction. It's helpful to think about, why did I go there? I wonder what caused me to feel that way. And then maybe to journal some of those thoughts so that you can stay ahead of your own feelings and be able to identify where problems might come up. Very important for your success to follow the guidelines. We want to be careful not to give ourselves permission to sway or to listen to advice from helpful or not so helpful others that say, oh, I did this and it was fine, or I heard about this and you can do that, that's fine. The more you can stay in the right lane and follow this pathway that's already been established, the greater you have for success. And that's why it's important to stay connected with follow-up visits. It's a great time to say, I was feeling like I could have indulged because I had done so good. What do you think? And be able to have those conversations. So build and invite support. This can be family, coworkers, friends, and it's important to recognize those that are supportive and those that are not so supportive. And it's okay to love our family and friends and still enjoy our lives together, but recognize those people that are helpful and those people that might not be as helpful. And by all means, Life Without Limits provides supports continuously. Join in-person and online classes and programs. The Back on Track classes are a great way to come in with other participants, linger in the background, listen to what other experiences people have had, or jump right in and share your own and be part of the conversation that helps others as well. You'll find this is a supportive community. The behavioral and nutritional and fitness events are also a great way to practice those new behavioral habits that hopefully you're going to develop as you recognize the changes that you're having with yourself in this journey. Celebrate your successes, and these include many more than just scale and weight successes, but successes like maybe shopping in a way that you didn't before, or somebody offering you a compliment or a comment that really makes you feel positive about yourself, or just activities that you didn't participate in before or you may have avoided and now you're finding yourself exploring. These are great successes and important for you to celebrate because it's much more than just a number on a scale. So what can a life without limits look like? More confidence, more pride as you conquer areas of previous struggle, less shame, better energy. If you think about the weight that you may be carrying that is something that you can't put down, and afterwards you could feel a relief that you can, and you have more energy, less joint pain, less immobility, fewer medications and the costs associated with that, better engagement with your kids and your grandkids, being able to say, yes, I can do that activity that maybe you avoided before. Less social anxiety. And this is a really important piece to think about in terms of feeling like you can be part of a more normed part of society. This could be airline seats, roller coaster rides, movie theaters, even just moving through crowds of people or shopping in a way that maybe was inhibitive to you before and now you feel more confident and comfortable doing. So again, this is a journey and it's your journey.
Hi, I'm Velvet and I work at Life Without Limits in the referrals and authorizations team. I'm going to talk to you today on a little bit of what is necessary with your insurance company to be qualified for bariatric surgery. One of the biggest questions most are going to have is, do you qualify for bariatric surgery? The first step before considering insurance or other payment methods is, do you fit the criteria of your insurance company? Typically, insurance companies require a BMI of 35 and greater with 2 comorbids, or a BMI of 40 or greater with or without comorbid conditions. Medical weight management may be required. All your insurance companies require a behavioral health evaluation, a nutrition class, and a letter of medical necessity from your family doctor. If you think bariatric surgery might be right for you, you can contact me directly at our office at 231-246-1123, and I can schedule you for a consultation. After your consultation with Dr. Gluck, you can expect to be set up for a nutrition class, behavioral health appointment, weight management visits if your insurance requires it, and any other diagnostic testing based on your medical history. Please begin collecting the following medical information. We may need a letter of medical necessity from your family doctor. Some insurance companies require consecutive months of weight loss attempts. If you've already started this, please have any existing records sent to us. You will want to know what your insurance covers. Requirements for approval depend on your individual policy. Call your insurance company to see if bariatric surgery is a covered benefit. You can find your number on the back of your insurance card, and you'll need to give them your contract or policy number and group number. They may ask for procedure codes. Code for the sleeve is 43775. The Roux-en-Y is 43644. And the diagnostic code that you will use is E66.01. Ask them what is the criteria to be approved for surgery. Also find out if there's a copay or a deductible. Is there a separate copay or deductible for the hospital, separate from the surgeon? And do you need a referral for the consultation? Once you call your insurance company and check your benefits, we're going to help also. We will verify those benefits. We're going to review your specific plan requirements with you at your consult. We will submit all the documentation to get approval for surgery, and we will provide you examples of any documentation that is required by your insurance company if needed. If you find out that your insurance company does not cover bariatrics, we do have cash pay options. $11,000 for the sleeve, $15,000 for the Roux-en-Y. We do have finance options with companies such as Care Credit. Your insurance should cover any diagnostic testing or preoperative consultations. You may need a referral or authorization for these services, and always check with your benefits for special copays and deductibles. Your insurance may not cover the behavioral health evaluation. You're going to want to call your insurance company to see if that is a covered benefit, or you could pay cash for that as well. Our one-time program fee of $300 is one fee that no insurances cover. On the screen are some helpful websites that you can go to: obesityhelp.com, obesityaction.com, asmbs.org, and of course our website, drbriangluck.com.
Bariatric surgery is a life-changing event. You have to be motivated and willing to commit. Certainly you have to follow the dietary restrictions, adhere to exercise, take the vitamins necessary, comply with follow-up, manage emotional eating and other disordered eating symptoms, and seek and use support. What I think you've understood is surgery alone does not equal weight loss. Patients must remember that the operation is the first and not the last step toward recovery. It is a tool that allows you to help yourself, but there's a personal responsibility that cannot be given to anybody else. And what we feel here is weight loss is 10% surgery and 90% follow-up. And I think what we do better than most is teach lifestyle. So when you start doing this as a surgeon, you realize that there's probably nothing better professionally you can be doing than watching your patients go through this and go through the non-scale victories, like jumping out of an airplane or water skiing or going down the luge at the Michigan Winter Park. We love to watch our patients do this kinds of stuff. This is what makes it worthwhile for us. Thank you for watching our seminar.